Welcome to our Johns Hopkins University School of Medicine Biomedical Informatics and Data Science graduate training program, to our monthly Grand Rounds speaker series. My name is Paul Nanji. I serve as the Director of Education for our training program, and it's really a pleasure to be with you here today. It's really a great pleasure to be having Dr. Tessa Cook as our speaker today. She's a close friend of mine, and she serves as the Associate Professor of Radiology at the Perelman School of Medicine at the University of Pennsylvania in Philadelphia, as well as the Vice Chair of Practice Transformation in the Department of Radiology. She is currently the Chair of the Society of Imaging Informatics in Medicine, but most importantly, she is an alumni of Johns Hopkins, having gotten her undergraduate degree in biomedical engineering. She completed her doctoral work in quantitative image processing in the Penn Image Computing and Science Laboratory. And during her residency, she developed Radiance, an open source radiation exposure monitoring tool used worldwide in the 2010s. Her research sits squarely at the intersection of imaging informatics and health services, and serves in various roles while she's pursuing innovative methods to enhance the delivery of longitudinal patient care in radiology and improve radiologists' workflow. She is the director of the Imaging Informatics Fellowship in the Department of Radiology, as well as the clinical director of the 3D and Advanced Imaging Laboratory. She has received numerous awards. She's received the 2011 Stephen Amos Jr. Fellowship Award in Quality and Safety from the ACR, as well as the AUR J. Giraffe Fellowship from 2013 to 2015. And in 2020, Dr. Cook was inducted into the College of Sim Fellows and also received the inaugural Dr. Ruth Dayhoff Award for the advancement of women in medical imaging informatics. And so it's a real pleasure to have Tessa with us today. I'm really excited. Tessa is really a group of a new generation of researchers in radiology that are really taking imaging informatics and really connecting it with the rest of biomedical informatics in the community. So Tessa, thank you so much for being here.
Thank you, Paul, for that very kind introduction, and good afternoon, everybody. I'm really delighted to join you all. As Paul mentioned, I am a proud Blue Jay alum, and always nice to come back to Hopkins and meet folks, even if virtually. So I'm going to speak this afternoon about the future of imaging informatics across the enterprise. As you saw earlier, I have the following CME-related disclosures. I also have a number of leadership roles in various radiology organizations, and I want to let you know in advance because I'm going to refer to some of these organizations in the presentation and want you to know about the work that I do with them. I also have some grant funding related to informatics and AI research. So we're going to discuss imaging informatics and the role that it plays in the healthcare enterprise and how it can enable the quintuple aim in healthcare. And if you've been following along, you know that this originally started as the triple aim, and we've added a couple more goals along the way. And there is a very relevant and critical role for informatics in helping us achieve this. Some of you might be new to the field and might be wondering, well, what is imaging informatics? And if you ask Wikipedia, Wikipedia will tell you that it's a subspecialty of biomedical informatics that has to do with all things medical images, how we use them, how we share them, how we store them, and the efficiency of all of those processes. What I hope you'll come away with at the end of my talk is the realization that imaging informatics has so much more about it now than just image data, than just pixel-based data. And quite frankly, if you ask the American Board of Imaging Informatics what the specialty is about, they will present it as the intersection of information science, computer science, and healthcare. And you can imagine the vast variety of data that exists in these three domains. And so certainly imaging informatics has to do with how medical images are exchanged and used in complex healthcare systems. But there's so much data that accompanies those images. Data in the medical record, real-time monitoring of patients, and certainly now all of the additional data that we can potentially extract from the observations that we make of patients that may not necessarily be directly appreciable to the human eye. And so imaging informatics really encompasses so much more than images. There's also some debate frequently as to whether it's informatics or it's IT. And I would like to argue that it's both. Informatics has to do with how we as humans interact with information, all of the interfaces between us and the systems that we use and the technology that we use to take care of, in this case, patients. Information technology is the infrastructure that enables that. It's the computers and the networking and all of the system connections that enable us to even have these interfaces. So I would argue that you can't have informatics without IT, but they are in fact two very different fields. But they are both absolutely essential for the success of imaging informatics. And there are many imaging informatics specialty societies across clinical domains as well. There are standards developing organizations like DICOM and HL7. There is IHE, which is the Integrating the Healthcare Enterprise Initiative, an international effort to take existing standards in healthcare and create frameworks for interoperability of the technologies that we use to take care of our patients. There are specialty-specific informatics societies across radiology, pathology, ophthalmology, dermatology, and others. And there are additional societies that work across both the clinical and the research domains on the technical side. And one of those, as Paul mentioned, happens to be the Society for Imaging Informatics and Medicine, which I'll talk about a little more in a couple of minutes. There are many hot topics in imaging informatics, and you might wonder why there are so many informatics specialty societies, and it's really because there's a lot of work to be done in this field. And again, these cross-clinical specialties, I know I'm speaking to a primarily radiology audience, but it's important to remember that there's imaging elsewhere in the healthcare enterprise, and that there are encounter-based imaging acquisitions, but there are also orders-based imaging acquisitions, and we're used to more of the latter. Someone places an order for an exam, the patient comes to radiology, or similarly in for our cardiology colleagues, the patient goes for an echocardiogram or something like that. But there are also encounters-based imaging workflows and instances that are important to remember. And so all of the standards that are required to make sure that this imaging data finds its way into the appropriate part of the medical record and is accessible across the healthcare enterprise to the clinicians that need it becomes very important. And leads naturally into enterprise imaging and how we can handle these very heterogeneous types of data and make sure that the people that need them are able to access them, including, I should say, our patients. There's a lot to be done still in workflow optimization in medical imaging and imaging informatics, despite all of the work that we have done over the years. And certainly now you can't turn your head without hearing about artificial intelligence across medicine. And so that has kept many of us busy and learning new things and learning about how this technology can be best used to improve the way we care for patients. Because at the end of the day, we do all of this for our patients. And so a lot of imaging informatics is also involved in increasing the patient-centeredness of the care that we deliver, helping to engage our patients more effectively in their care, improving their experience of their care in medical imaging as well. So I am the chair of SIM, whose mission is to advance medical imaging through innovation, research, and education. And SIM is very unique as a professional organization because of the different personas that are represented among our membership. Not surprisingly, we have clinicians and imaging informatics specialists, but we also have our industry partners, we have developers and data scientists, we have researchers. And so it's really a phenomenal group when we get together, because you have so many different types of expertise represented in all of these different roles that work together to advance imaging informatics. And so it becomes a place where you can really have some disruptive technologies, cutting edge research, gives everyone the opportunity to collaborate across medical specialties. to have direct conversations with our industry partners who are also helping to advance the field, and also to support career development for folks that are new to the field, for folks that have been in the field for some time. And so having this group of diverse experiences and areas of expertise, I think really is what sets them apart as a society. We recently completed our strategic planning process and have our new strategic plan that is available online if you'd like to learn more. But there are 4 pillars to this strategic plan. Research, leading discovery and innovation. Education, making it accessible and customizable for those different personas and for different levels of expertise. Technical harmonization, again, working to advance interoperability. And a culture of belonging, forming an inclusive and diverse community for our members. And this is really intended to be a global community with multidisciplinary peer networks, with a focus on growth and partnerships with other societies, as well as fiscal responsibility. So that's a little bit about imaging informatics and about SIM in general. But let me tell you a little bit about informatics across the enterprise before we talk more specifically about imaging informatics across the enterprise and where the future might take us. So back in 2014, the ONC laid out these 5 goals in their Federal Health IT Strategic Plan. And just to set the stage a little bit, remember that the 5 or so years preceding 2014 were the era of meaningful use and increasing the meaningful use of healthcare IT, the sudden spread of the electronic medical record across the healthcare system in the US, and sudden creation of large quantities of electronic healthcare data. And so ONC laid out these 5 goals, expanding the adoption of health IT, again, continuing what had begun with meaningful use, advancing and creating the access to secure and interoperable health information, improving care delivery, advancing the health of not only individuals, but also communities and populations, and of course, advancing research and innovation. All noble targets, I think you would agree. But what actually happened in the years that followed as the EMR became ubiquitous and all of this data started to be created? There's a very nice article from a couple of years ago that looked at patients' access to medical records and sort of some of the unintended consequences. There was definitely a preference for patient portals over verbal delivery of information, at least in this particular systematic review. The downside was, even though healthcare information became more available, it didn't always come with the necessary context to be understood. There were not always explanations that accompanied that information. And so there were some ethical considerations there. Giving patients more information certainly empowers them in their care, but also perhaps transfers this unwelcome sense of responsibility to the patients now to manage their care. There was disagreement between patients and clinicians as to how much should be shared and how it should be shared. And there's also some concern that it would actually increase or amplify pre-existing health disparities in cases where patients did not have great access to care and may not have similarly great access to their health information. Many of you have probably heard of the 21st Century Cures Act. It may impact your daily practice as well. So this went into effect last April and included an information blocking provision that required test results to be made available to patients in the medical record, in the patient portal, almost immediately. And the goal here, again, was seamless and secure access, exchange, and use of electronic health information for patients, but also for providers. And with the provision that patients would not have to pay for access to their health information, which makes sense. But there was a really unexpected, unintended consequence of this. And that was that in many cases now, patients were getting results before their physicians who ordered the testing had a chance to get the result, figure out what it meant for the patient in the larger context of their care and their health, and make a plan going forward. And it actually created more anxiety, created more phone calls from patients to doctors' offices. And so this was one of the unintended consequences, and we're still sort of working through how to best manage that. All of the impetus towards increasing the use of the EMR and the creation of electronic healthcare information was suggested possibly as a cause of physician stress and burnout. And so this group wanted to look at that through a series of surveys of physicians in different specialties. And they found that health IT related stress was actually measurable, quantifiable. They found it in 70% of the respondents to their survey. They observed that it was actually worse for primary care and family medicine type specialties. And in their analysis was actually an independent predictor of burnout. So even though the goal was to help to improve care delivery, there was a negative impact on the physician and provider experience. This was a group who looked 5 years ago now at the impact of the EHR on the primary care physician. And they estimated that on average, PCPs were spending about 2 hours interacting with the EMR for every hour of patient contact. And that included 4.5 hours during the workday, another hour and a half in the evening. So anywhere from 6 hours, up to 6 hours of an 11-hour workday spent interacting with the EHR. So again, many, more than a few articles in the literature suggesting that the era of the medical record, of the electronic medical record, may have contributed to physician burnout, despite the fact that it was initially proposed as a solution. Atul Gawande writes many articles and books, and I particularly like this one because it has to do with his and his colleagues' experience of the medical record. It's a long article. It's definitely worth a read if it's not one that you've seen before. But at one point in the article, he said, I've come to feel that a system that promised to increase my mastery over my work has instead increased my work's mastery over me. And that we ultimately just need systems that make it better, make it easier to take good care of our patients, and that strengthen the human connection. And you've probably all had an experience where you've had a doctor's appointment where your physician is looking at the computer at least as much as they're looking at you, if not more. So looking at whether or not the medical record helped with health information exchange, in this particular analysis, providers used all of that additional information for fewer than half of the referrals that they made. And so despite all of the efforts created to make electronic medical records, make health information exchange available, there was not a whole lot of uptake. And this is only a paper from 2021. Additionally, looking at the early days after the information blocking provision and 21st century cures went into effect last April, there were many more health information exchanges now than there were a decade ago in the early days of meaningful use. But these researchers found that there was still information blocking occurring. And part of it had to do with the prohibitive cost of EHR systems, rather than to health systems themselves being unwilling to share their information. And so there's still work to be done. And I'll also share this article with you briefly, which had to do with looking at the first 2 months after this provision went into effect, a survey of clinicians at MGH. 84% of those that responded said that the volume of phone calls that they had received had gone up after immediate report release to patients had been implemented. So lots of unintended consequences, lots of impact of legislation and regulation on informatics in the healthcare system. And again, I wanted to remind you of the quintuple aim of healthcare, because informatics comes directly into play here. Improving population health, enhancing the care experience, decreasing the cost of care, improving workforce well-being, which we've just talked so much about how that didn't seem to happen with some of these initiatives, and addressing health equity. And so as we talk now about imaging informatics across the healthcare enterprise, how can we address some of those aims? So I'm going to share with you 3 initiatives that we have been working on at Penn over the last few years, not necessarily entirely in this order, and they all do overlap to some extent as well. Improving rates of imaging-based screening, closing the follow-up loop, and streamlining communication between radiology and our emergency departments. So starting first with improving imaging-based screening rates. You know, it's in the perfect world, in order to get a patient the imaging-based screening they need, you would probably just tell them or tell their clinician, and then that would get the patient the screening that they need. Now, we all know it's not nearly quite that simple. We see campaigns for mammography, lung cancer screening, colorectal cancer screening every year, and we know that patients at risk are not getting the screening that they need, despite the fact that there are communications from many different modalities, if you will, both medical and in the community. So the other thought is, well, all you really need is someone to place an order for a screening exam. The patient will get the scan, right? Well, again, it's not quite that straightforward. Depending on the type of screening, you've got to figure out whether they're at risk. Someone has to talk to the patient, explain why this is important. The patient has to agree to get the screening study. And then even after the order is placed, there are all the logistics of actually getting them there before they can get their imaging. And then if the screening study is a non-negative study, then you've got to consider the follow-up and the management of anything that was detected. And if any of these steps fail, it's possible that the patient falls through the cracks. And this is that cognitive burden that our referring clinician colleagues are constantly facing amidst getting all of the other aspects of their patient's care managed and addressed. So we started to look at this from the perspective of hepatocellular carcinoma screening, HCC screening. The guidelines say that patients at risk should get a screening abdominal ultrasound every 6 months. But this is not quite as straightforward as screening mammography, where if you're a woman and you're aged 40, the recommendation is to start getting annual screening mammography. With risk factors for HCC screening, there are actually nearly 24, depending on the criteria that you look at and the additional expertise that you include in the decision-making process. And so we found that, knowing who was eligible was difficult, and that of our eligible patient population, the best case scenario was about 60% of them were getting their screening. In many subpopulations, it was actually less. And not surprisingly, they were there were competing priorities to getting their screenings completed. Only 60% were getting their screenings ordered. However, if they got their screenings ordered, they were fairly likely to get them completed. And so there were obviously some competing needs here and competing priorities that prevented patients from getting their screenings appropriately. And so what we tried to do was look for a systematic set of solutions, because this was not a single issue that needed to be addressed. There was not one person at fault for someone not getting their screening study. It really was a multifactorial problem, and it needed a multifactorial solution. And so we started with being able to identify the patients at risk, prime the clinicians to place the orders, and then engage with the patient to get their screenings completed. And so we created a platform called Livaware. This is not a commercial product. This is an in-house platform that we built with the initial use case of HCC screening, but also now we've expanded it to other use cases as well, to reduce the cognitive burden on our referring clinician colleagues, our primary care colleagues, to help them improve imaging-based screening rates for their patients. And so we spent a long time developing this query to identify patients at risk and created a dashboard for different clinics so that we knew when a patient had an upcoming visit with their primary care clinician and was also overdue for their HCC screening. And so for those patients, we created a pending order, a temporary order in the medical record with a lot of instructions about what they needed, how to get the study, where they could go, information about the pilot program for the clinicians themselves. So when they opened up their encounter and saw this order, they knew what it was about, and gave them the opportunity to very simply click sign or cancel. And then we tried to engage directly with patients over the phone, through the patient portal, and did a small pilot where we offered same-day screenings to patients who had upcoming appointments. And so with our phase 1 pilot, we looked at a single primary care practice and identified 23 patients across multiple PCPs in that practice who were at risk for HCC and overdue for their screening. And we pended orders for those 23, but then we realized as we were going through this iterative process of refining the query that 6 patients actually didn't meet criteria for various reasons. And then of the ones that did meet criteria, we didn't realize that there were 3 patients who actually had completed their screening. And so of the remaining cohort, we had 5 patients for whom screening would not have been ordered if we had not nudged the primary care physician about the patient's risk factors. And so we went from our baseline of 60% of orders in this particular population up to 82%. And this was extremely well received. One of the primary care docs said, I didn't know the patient was eligible. I probably wouldn't have ordered it. So we definitely had some wins here in alerting primary care physicians to the fact that they had patients at risk who were overdue for screening. So we went from that very small pilot to a larger pilot covering 7 primary care practices in our downtown clinics with 1 control practice. We automated pending the orders so that we could scale this initiative rather than having someone manually create these. And screenings ordered increased anywhere from 11 to 31% over the baseline rates. And so we started looking further along to validate this algorithm, decrease the cognitive burden, and understand the barriers that patients faced in actually getting their screenings completed. Because when we looked at our initial data, we found that once you got a screening study ordered, you were fairly likely to get it completed. Now, I should tell you that occurred before COVID. And so this initiative went live 3 months before the pandemic. And although we definitely did see an increase in rates of screening completion in some of our 7 practices, our 7 intervention practices, we also saw decreases in rates of screening completion in some of the other practices. And so we're trying to actively explore what that looks like and what some of those barriers are, because we're also scaling this effort across our primary care service line. The beauty of this platform is that it scales much more effectively than having a group of people at each individual institution, each individual practice within our organization, or each individual hospital group trying to achieve the same thing. With the electronic solution, we're able to scale much more effectively and, more importantly, much more cost effectively, even though there is still a coordinator in the loop to help us with some of these efforts. It takes much less human power to achieve the outcomes that we're hoping to get to than it would without the solution. And so, as I mentioned, we're expanding this platform. We've used it for a number of precision medicine, personalized medicine oncology applications. We are expanding it to other use cases, lung cancer screening and screening mammography eventually. And we have adapted this for our next initiative, which is related to closing the follow-up loop. So for almost a decade now, we've had something here at Penn called RD, which is the Automated Radiology Recommendation Tracking Engine. It's driven by structured reporting that is generated by the radiologist, such that if there is a recommendation for follow-up, whether it's imaging follow-up, tissue sampling, clinical follow-up, that it's encapsulated in a structured template and able to be extracted into an external database that can be used to identify whether or not patients are getting the recommended follow-up or not. With the goal that ultimately, if there is a recommended follow-up, that it is a clinically indicated follow-up, that we're able to alert the clinicians and the patient gets the follow-up that they need. Of course, I don't need to tell you why this is important. We want to make sure that if these are findings of possible cancer, that we're catching them early, that patients are able to get the treatment that they need and have positive outcomes. There are certainly medical, legal, and financial impacts of missed or incomplete follow-up for the patient, for the health system. And the challenge here, as was the case with many of the other initiatives that we approached, was you needed someone to take responsibility for ordering an exam. And unfortunately for our primary care colleagues, that generally does eventually fall to them. And so what we were trying to do was make sure that if we did engage our primary care colleagues, it was relevant, that we did not create unnecessary specialist or surgical referrals, that we adhered to evidence-based guidelines, and we didn't overwhelm a system that already had limited specialist availability. And so we adapted some of what we did with Littlewear, some of what we've done with Artie, to develop the Penn Medicine Results Clinic. And what this does is it actually redesigns the patient experience a little bit, because in the past, if you had a finding, you would probably automatically get referred to a specialist for an appointment, even if ultimately the next step in your care was still imaging. And so we wanted to streamline that whole process, make sure that the patients that were seeing the specialists were ones that really needed specialist care, whether it was biopsy or something else, and to make sure that we could increase rates of follow-up completion. And so the Results Clinic was begun as a collaboration between the Departments of Radiology and the Departments of Medicine. And our first use case was the follow-up of incidental pulmonary nodules, specifically for subspecialty surgical practices, but also for internal medicine and family medicine. And again, we wanted to make sure that patients who got nodule follow-ups got the care that they needed, got their follow-ups completed that were relevant follow-ups in accordance with national guidelines, and that when they needed subspecialty care, they were able to get it and that we were able to facilitate that. And again, the goal here was really to take the management of these pulmonary nodules off of our clinical colleagues, particularly in the cases where the clinical specialty did not necessarily align with the thorax. So we developed a process that included a dashboard and a set of criteria to identify these patients, integration into the EMR for messaging of the referring clinicians to prompt them to consult the Results Clinic if they wished to help us manage the follow-up, a series of coordinated communications to the patients with the assistance of our colleagues in pulmonology, and with the use of telemedicine, which has burgeoned in the last couple of years, thanks to COVID, and all with the goal of making sure that patients who needed imaging follow-up for their pulmonary nodules were able to complete their follow-up, and at such time as they might need pulmonology referral, that we can facilitate that as well. So looking at our preliminary results, we launched a little over a year and a half ago now, last March. We started with 3 surgical subspecialties, ENT, urology, and neurosurgery. Soon after that, added the Department of Family Medicine and Community Health, and so after that, the Department of General Internal Medicine. We had a coordinator who was reviewing and facilitating the messaging to the clinicians. We had a nurse practitioner supporting the televisits to patients, a radiologist who was helping to ensure the appropriateness of the outreach to the patients, and the developers, of course, that built the system for us. And so these were our early results we presented at RSNA last year, looking at the number of patients from these originally 4 and now 6 clinics, and the number that needed follow-up, the number that we engaged their clinicians, and the number of responses. And we had surprisingly good response rates and enrollment rates for these patients. And at the time had about just under 30 patients that had completed their consults. Fast forward a year later, we have well over 1,000 patients in the pipeline being cared for by the Results Clinic. And again, are also starting to spread this to new use cases beyond pulmonary nodules. The grand vision is that this is going to be an enterprise-wide service that will manage all imaging follow-up if a clinician would like us to do so. So changing gears a little bit and considering ways that we can even indirectly improve the patient experience in radiology. In this particular instance, improving both our colleagues' experience, both in radiology and in the emergency department, but also empowering them to take better care of their patients by increasing the communication between our departments. This resonates, I'm sure, with anyone that has done a call shift for the emergency room. Typically the way that you communicate with your colleagues in the emergency department is by picking up the phone. We call them, they call us, and the shift essentially proceeds with a whole lot of phone calls in either direction. And my residents will tell me that this is probably one of the most frustrating things about being on call, is constantly having to answer the phone. And so even though we have certainly shared goals, our emergency department wants to get the patient to some disposition, whether it's admission or discharge or some sort of treatment. And we in radiology want to facilitate that and enable that. And the secret to making this happen is really improving the communication between our departments, because that helps to improve the care that our patients receive. And phone calls are really just not the way to do it. And so we started to think about what some of the most common questions were between the two departments, and particularly from the ED calling radiology. Where is my patient? I know I ordered a study. How soon might they be able to get it? My patient came back from their imaging study, and chance I might be able to get a report. I have a report and I have a question about it. How do I reach the person that read it? And so this was actually an initiative that we started that was one of our innovation challenge projects from one of our residents, Dr. Ali Denaliwala. And he wanted to figure out how to answer these questions without someone having to pick up the phone. And so he created this. This is the ED board, as we call it, which has columns for orders, for completed exams, and for reported exams, with names of the interpreting radiologist, phone numbers so that the most frequently populated reading rooms could easily be accessed, expectations based on turnaround times for different modalities, for image acquisition, but also for reporting. And we piloted this in one emergency room in one of our downtown hospitals. They put it up on a big central monitor in the ED, and also had the ability to access it on their own individual workstations. And this was incredibly popular, so much so that all of our downtown hospitals then wanted it, and now all have it. And now our suburban ERs are asking for it. And so we're trying to figure out how to build it for those suburban hospitals as well, which have slightly different systems than we do. So this is just a flavor of some of what we've done for imaging informatics in the health system, and how you can imagine that the future of imaging informatics might support care delivery. There have certainly been some unintended consequences of the expansion of health IT across the enterprise over the past decade. But there are many innovations that can help to improve patient care, physician experience, and population health, and really get us eventually to that quintuple aim, although I would argue that we're still sort of working our way down even the original triple aim of healthcare. You'll notice I didn't really mention artificial intelligence at all, and certainly AI is going to come into and is going to play a significant role in facilitating a lot of what we do and helping us to scale some of these efforts and also start to look at ways of identifying patients for screening, for opportunistic screening that we may not have been able to do in the past. But all of these platforms that help us to manage and coordinate getting our patients to the screenings they need, to the care they need, are still necessary, because even though AI will enable us to identify those folks, we still need to make sure that we're doing effective outreach. And sometimes the outreach requires a human element rather than a computerized element, and that becomes very important. So I want to acknowledge a number of different groups that have contributed to this work, and a number of different individuals that have supported it over the years. Darko Lalovic and Charlie Chambers are part of my team at the Center for Practice Transformation. They are the brains behind all of what I showed you today that we've built over the years. I'm very fortunate that the leadership of my department has been very supportive of our informatics initiatives. We have great collaborations with the Division of Pulmonary Medicine or in the Results Clinic. Dr. Hannah Zuffer is a good friend of mine and colleague in abdominal imaging, and we've worked on follow-up recommendations and systems for over a decade now, which is kind of hard to believe. And so many students and trainees that have come through along the years that have supported and advanced these efforts. LiveAware is currently being funded by Independence from Blue Cross for a specific use case through their Clinical Care Innovation Grant, and I'm very grateful for that support. The Center for Healthcare Innovation helped us get it off the ground. Roy Rosen is our Chief Information Officer here at Penn Medicine, and he and his team have taught us a whole lot over the years about how to do innovation and practice transformation work. And I'm very grateful to be able to run the Center for Practice Transformation here within the Department of Radiology that supports these initiatives, among others. So with that, I thank you very much for your attention. We have some time for questions, and I see a couple in the Q&A as well. Paul, should I just jump right in? How would you like to do this?
Tessa, thank you so much. That was great. It really reminds me of Bob Wachter in his the dawn of the computer age in medicine, and how we're now entering in the era of re-engineering workflow. And so we'll go through the question, but I have one question ahead of that. And that it really reminds me of, I really love closing the loop. I really like, enabling better collaboration with physicians outside of radiology. But you're sitting on different platforms often between the PACS and the dictation system and the RIS versus the EMR and the enterprise solutions. And so I'm interested in is, as you go about these re-engineering efforts, is there, enough work being done on for these platforms to have enough APIs for you to be able to hook them in, or are you having to build, third-party independent solutions to try to track some of these important collaborations?
Yeah, that's a great question, Paul. Everything I showed you has been built for the most part outside of the EMR. No. It has hooks into the EMR, certainly, but generally not through any available APIs at this point. A little bit for some of the messaging, but for the most part, we are tapping into various databases and data warehouses to get what we need. And then the applications and the dashboards and all of that are built externally because we have the flexibility and the access to be able to do that. If we were limited to working within the EMR, we would be very limited, quite honestly, in its current configuration for us. So most of what we've done is gotten the data that we needed and built these systems externally so that we have oversight of them. We have ability to expand them and fix them as needed. But we try whenever possible to tie them back in as appropriate, because we don't necessarily want our referring colleagues to have to go to 6 different places, but sometimes they do have to go to at least one different place.
And I know that EMRs have some APIs, but I think this is so important for our future that right now most of our EHR systems are documentation systems, and they're really not they're not really enabling collaboration and these reengineering efforts. And so I am certainly hopeful as we go through these efforts is that we have all these great ideas, but you get stymied when the platform is not able to communicate or be able to have an API to integrate it with it. So I just think that it's fantastic that you're demonstrating the value of these workflows, and it's also a shame that you have to build it outside of the platforms which we use to deliver care. And so I think that it's just it's a kind of a testament of where we are as an industry right now. Yeah, so let's go to the questions. Our first question is from Cindy Kai. Cindy is an ophthalmologist. She's one of our KL2 informatics students, and she wants to know, her question is a little bit more about how can she help vendors within ophthalmology become more DICOM standard adherent, which is really a key piece of getting data out of these systems that we can then use.
Yeah, Cindy, that's a great question. Thank you for asking it. You know, I won't say that radiology has necessarily solved that. It is something that we continue to engage with our vendor colleagues and industry partners on. I would say one of the strategies that has certainly been recommended to me is to continue to have those conversations and stress the importance to your vendor colleagues, your industry partners of why adopting these standards becomes so important, and the value that it provides you as the customer for your systems to be able to communicate. It does, I think, take some activation energy in every specialty, and you know, I'm certain that was the case for us in radiology in the earlier days as well. For some of the newer standards, that continues to be the case. Getting engaged with IHE can be very helpful because there are clinicians and vendors involved in development of IHE implementation profiles. And then that can also be a way to then go back to your vendor colleagues and say, you know, there is an implementation profile for this. This is what we need. So a lot of that is happening now for artificial intelligence workflow and results on the radiology side, but it might be a good starting point. Engaging with folks at SIM, and again, full disclosure, I am the chair, but it is a way to engage with folks that have done that on the radiology side to get some real practical advice on how to approach it for ophthalmology as well.
Yeah, I think there's some good suggestions. I know that it's really a multi-factor question for adoption of standards for vendors. And I do also remember that one of the big things was getting a large customer like the VA to adopt the standard, and that kind of drove so having the government saying we're going to purchase only these instruments that comply with the standard really drove some of the adoption as well. But I would agree with you that SIM is a great place to also, another good way to do this is making the vendors look good by demonstrating those by demonstrating the standards and having some sort of demonstration like we do with IHE to show off the ability to communicate in complex real-world situations amongst multiple systems. Okay, so next question is from Robert Koski. He is he's just a recent alumni of our program. He's a dentist, and he had a few different questions in here. One of them is, where do you see are some of the biggest gaps in the existing standards for imaging informatics, and how do these gaps impact the ability to gather data on medical imaging?
I'm scrolling through Robert's 3 different questions here. So I'm going to tackle the first 2 real quick as well, related to LiveAware. I'm going to go backwards, Robert, sorry, out of order here. So the biggest barriers, this was, we started this effort in 2018. We did not actually go live in our 7 primary care practices till December of 2019, and we all know what happened in March of 2020. So yes, there were absolutely some barriers, given that it took us, a little over a year and a half to go from concept to implementation. A lot of it was governance. There's a complex governance structure here, and also wanting to educate the referring clinicians that we're going to start to see these pending orders. And I would say, as tends to be the case in informatics, about 80 to 90% of it is people, and about 10 to 20% of it is the technical stuff. And that was absolutely the case for us too. Most of what we had to do was convince folks that we needed access to the EMR, that this was not going to break the EMR, that we were actually doing something that was going to be helpful to our referring clinician colleagues, and also spending time to let them know what it would look like. And a lot less of it was building out the actual informatics tools. We did spend a little time, a decent chunk of time validating the query. I will say that, because that was a very iterative process to make sure that we were not over sampling and creating false positives, essentially. In terms of barriers to resistance from the providers, not really. I mean, we are imminently scaling this across the entire primary care service line. Once they saw it and they got to experience it, they really love it. And so it's really been very gratifying to have built something that is that welcome in their workflow. But getting to your third question, what do you see as the biggest gaps in the existing standards, and how do they impact the ability to gather data? I think the gap is not so much in the standards, but in the implementation and availability of those standards in the tools that we use. I run, as Paul mentioned, our informatics fellowship, and I was talking to the fellows during our last session about structured reporting and MRRT and a template standard that would allow us to be able to share our reporting templates more seamlessly across systems, which I think has a little bit more uptake in the vendor space now, but took many years to even get to this point. And I think that is really the biggest challenge is, the standards are developed. There's an XKCD cartoon, right? There are 15 standards. And then by the end of the panel, there's a 16th standard, and it's not even one standard to rule them all. We just keep building standards to try to get something implemented in the tools that we use. And so I think the real gap there is getting our vendor colleagues, related to the earlier conversation, to actually help us implement some of these things that would make our work easier. There was also a question from Robert Miller. So yeah, all of these are integrated to some degree with the EMR, but really more so in for the purposes of data flowing out rather than us putting data back in. And again, that has to do a little bit with the governance here of what they are comfortable with us doing with the EMR. But everything is automated. The integration is real time. The messaging, the pending orders is all automated now. We did start out with that earliest pilot. It was done manually, but it was a very small pilot, so that was feasible. But it has been automated, and it has been running through the entire pandemic, essentially, even a little bit almost through the entire pandemic. I think we implemented that in 2020. But yeah, none of this work would be possible without that connection. I mean, we really need the data to be able to make these things happen.
So I come from a bygone era when we had film. And I don't think, today's culture remembers what it was like back then, where we had, we had a lot of physicians working, side by side with radiologists, helping them interpret the images and understand the course of treatment for the patients. And consultations, that in-person collaboration dropped by 95% when we introduced this technology. And that really has been, so it's really, I just love that I'm seeing that you're able to reestablish relationship, and it's really it's shown as a positive relationship, especially for, in the case of primary care, where we're finding that, that it is hard to remember follow-ups and making sure that the right thing happens, because there's something in the mind of the radiologist they write it into a note, but that is hard to encode in a way to ensure that something happens to the patient so that we can make sure that we don't lose track of that concern. And I guess, where do you see this going? I guess is what I'm hoping to see is, are we going to see more collaboration? I know we have, we certainly have a productivity challenge and we have a staffing issue in radiology, but I guess do you see as coming to the future for collaboration for the radiologist?
Yeah, that's a really interesting dilemma, because I think many of us would like to do more face-to-face collaboration with patients, with our clinical colleagues. Certainly we do tumor boards and multidisciplinary conferences and things like that. But, especially as it pertains to 21st century cures and where we can, make some impact there with informatics. I did talk about this at RSNA. I didn't include it here in this presentation, but making reports more accessible, understandable, in particular to patients, because they can get them now, but they're written for other clinical colleagues. And so, systems, and we certainly have one in-house. There are commercial systems out there that do this, but also giving patients the ability to sit down and have a consultation, even if it's virtual, with a radiologist. Different groups have tried this. We have a paper that's under review right now, but folks at Harvard have done this, where they embedded a radiologist in the PCP telemedicine clinic. So everything was virtual because it was during the pandemic, but it gave the patient the ability, while they were in their telemedicine visit, to talk to the radiologist about their imaging. Those are really, I think, meaningful interactions for patients, for radiologists. But our current workflow, our systems are not set up to facilitate that. And so what I'd like to see is informatics solutions that actually make that more realistic. And whether that's going to be AI that helps us with that, whether it's going to be external pressures of, the transition to value-based care that helps make that a reality. I think it's going to take some combination of things, but as far as the collaboration, I think we really need to explore what we can do with our informatics solutions. AI sort of burst onto the scene as, oh, well, this is the new robot radiologist, and we know that that's just not happening, for us or for many other clinical specialties. But we really need to use AI to help us leverage what computers can do well. And that frees up humans to do what humans can do well. And I think we're still figuring out exactly how to make that a reality in the clinical workflow. But I'm hoping that that's the direction that we're able to go in the next, 5-10 years.
Yeah, I do too. I think it's wonderful that we're able to more directly engage with patients. I'm also hoping that we can more directly engage with referring physicians. And I know we've done lots of pilots that have kind of fizzled out, where we would try to get a radiologist virtually doing rounding, doing obviously it's incredibly important to have radiologists part of tumor boards, but really trying to help, try to help people in the diagnostic phase as they're trying to understand the patient's treatment. And so I still feel like there's still a big gap in radiologists supporting the other specialists and physicians throughout the health system as they're trying to use radiology imaging in the diagnostic and therapeutic stages of the patient.
We have an e-consult program that Dr. Suresh, one of my colleagues, has run, that has been incredibly successful, very well received. She ran it almost single-handedly for a while. She was managing all these consults by herself, and now has a sort of a small team of us from the different specialties to pitch in. But was also presented at RSNA and very well received. But yeah, we're making, as you said, baby steps. Small pilots that are heading in the right direction for a lot of these things. But it really is going to take systematic change at some point to make it part of the workflow, an expectation of the workflow, rather than this other thing you also have to do while you're reading cases.
Well, I think that e-consult is fantastic. My question to you would be, what percentage of all the cases that are read is there going to be a physician-to-physician conversation about? And I still think it's a lot lower of a number than I think that it could be or should be. Now that we have a lot of our referring physicians are finally on telemedicine platforms, and they're more comfortable. They're now comfortable with this technology, which really has been driven in the last few years. But I do see that if I had to take a guess, I would like to see that number, certainly in a pediatrics environment, closer to 20%. And I think it's far lower than that in an adult setting than it could be.
Yeah, I mean, I think there's two issues, right? There's how many of them happen now, which I agree is a very small number. But I also think that part of the fear of having something like this is that it's going to overwhelm the system. And I'm not sure that's necessarily the case. And I think we need to be bold enough to try it at a real meaningful scale and not in a small pilot to understand what kind of volumes we're looking at.
Exactly. I couldn't agree more. Tessa, thank you so much for coming today and talking about the future of imaging informatics. And I do think there's just a lot of innovation of connecting that with the other areas of biomedical informatics. And so it's just an exciting time to see all this innovation taking place.
Thank you, Paul, for inviting me. Really enjoyed the opportunity to share some of this work. And if anyone has questions, feel free to reach out. Paul knows how to reach me.
I do. Real pleasure. And with that, I'd like to close our Grand Rounds lecture series for today. And I hope everyone has a great month. We are not having a Grand Rounds in January, so I hope to see you back in February. All right. Have a happy holidays, everyone.